Thanks a lot, Fred. Hello.
Hi.
Welcome you, and I'm happy that you have time to have this small interview. I would like to ask you if you can introduce yourself a little bit more because you are, of course, instructor colleague and you serve for the IPNFA and you are teaching in the university. So please feel free and tell us a little bit more about you.
Well, my name is Fred. You probably have heard. I'm from the Netherlands. I'm 62 this year. So my professional experience is about 40 years. I graduated as a basic physiotherapist with a bachelor degree back in 1985. So it's exactly 40 years ago.
Mhm.
That's coincidence, 2025. And I started with PNF already during my examinations. My final bachelor work was about a patient with a spinal angioma, and he was treated in a rehab center somewhere in Eindhoven. It's a city in the southern part of the Netherlands. And I visited the treatment a couple of times, and the guy who treated him, the colleague who treated him, had been in Vallejo and used PNF approach on
Great.
this patient. So, and I was curious because I learned a little bit basic PNF in my basic education, but this was more sophisticated and enhanced and more functional. So I got triggered by that, and I followed my own basic PNF course back in '87 in
Mhm.
Hoensbroek with the two who wrote the book PNF in Practice, Matt Buck and Dominic Beckers.
Yes.
And that was in December '87, January '88. So I got my first paper in '88 about PNF. And I thought, like, well, interesting. And I looked further as a young colleague, as a young physiotherapist. I looked into what is physiotherapy offering, manual therapy, BOBA therapy, or NDT, we called it in the Netherlands. So I followed the course in there too. And I did a refresher course a couple of years later on PNF again with Dominic Beckers and Matt Buck, but there was Inge Berlin
Wow.
was there too. And that triggered me even more. So and from there on, I rolled on to level 3B, and then I went to what is that in Switzerland? What was it called? The city?
Hermitage in Bad Ragaz.
That was what I was, of course, in Bad Ragaz. That was the city name I was looking for. Yeah.
Yes.
And there I met Sue Adler. No, Sue Adler I already met also once in the Netherlands before on a lower level course. And she triggered me because at that moment I also was already a manual therapist. I did manual courses in the Maitland approach. And I had a patient. And she looked at me, Fred, you're not happy. I said, no, Sue. Basically, I wouldn't treat this lady or this gentleman, this patient with PNF. I would use a nerve mobilization technique and manual techniques. And then she just looked at me and she said, can't you do that with PNF? She turned around and walked away. That was her way of teaching. And I thought, like, can't you do that with PNF? I thought, wait a minute, upper limb tension test. Yeah. PNF pattern. What's the difference? A little bit the angle. Okay, wait a minute. A PNF pattern, an upper limb tension test. Yeah, I don't know if that is visible. There it is. And then, yeah, there is, of course, similarity. Of course, I can do that. Yeah, it was a PNF course, so I had to do with PNF. But you're, of course, allowed, and I still teach that to my participants in courses and students at the university as well. You are allowed to combine. You still need
Yes.
critical reasoning. So that triggered me to say, okay, when they are so open to use knowledge and techniques from other concepts, as long as you can integrate it in a concept like the PNF concept, it's an open concept. Hence,
Yeah.
I like the word concept instead of the word method, because a method would be you do A, B, C always. But a
Yeah.
concept is open. You can do A, B, C, but you can also do C, B, A or BCA or whatever order, as long as you're within the concept and you use the components. And that triggered me. I was triggered by Inge Berlin, by Sue Adler, later in Bad Ragaz, Sue Adler again. And there already I did a lot of research at that time. So I had with me, in the time we did not have computers and laptops, I had with me a stack of papers. And So I got the feedback, you are well read and you apply your knowledge on my final level 5B at that time. It will be now level 6 or
Yes.
instructor course. It's a different name, but it's the same lineup, more or less. And from there on, I became a member of the International PNF Association. I think that was back in 1997. At that moment, I was employed in a hospital as the chief of a department. And the hospital was in Germany, just over across the border in the Netherlands here, from the Netherlands, so in Rheine. And there I started to use that PNF more and more. I was a member within the IPNFA at that moment. I visited the first time in Hamburg, the meeting. I believe that was back in 97 or 98. I don't know exactly anymore. And from there on, I got more and more involved. And with my interest in background of research and science to support the clinical practice, I was already back in 2003. I believe I was introduced to or we started the research committee. Together with Tim Joston, who was at that moment a big part in the Vallejo program in California.
Yeah.
And from there on, I was in the research committee of the IPNFA from 2003 up to 2 years ago, I believe, right? I quit. Or I quit. We changed the rules. I did it long enough, and basically I did it almost like 20 years.
Mm-hmm.
And I started to teach courses first, of course, as an assistant back in 1997 after that course in Bad Ragaz. And I got my degree or my certificate as an instructor in 2003, I believe. So that's also 22 years ago now by now.
Yeah.
And since then, I always have been teaching PNF at university, integrated in the rest of my work, but also in several countries. I was co-teaching in Germany. I was teaching in Poland, in Turkey, in Korea, in Brazil, in India, several other countries. I can hardly count them all together.
Great.
So, that's me within the PNF world.
Great.
20,
Great.
Almost 30 years now.
That's
35
great.
years.
Yeah, Fred, that's great. And you meet very important senior instructors. That's also very good. So, and you said the research was really from the very beginning of your PT experience in. So, and you write a lot of article, right?
A
Some
lot.
in
I've published several articles.
Yes, some in your language and some
Yeah.
in English. So please talk a little bit about the content of this article.
My first article was in the Dutch journal because I'm native Dutch, so I was thinking like I can write best maybe first in Dutch. It's also a lower level journal, so I thought that's maybe easier. And that was called PNF Beter Begrijpen. And I made a word game of that because begrijpen is understanding, but grijpen is gripping. So, and our PNF grip, so was also, okay, is it a better grip or a better understanding? And I made tried to make a word play with the title PNF Beter Begrijpen. So it was about PNF. That was published, my first one in 2001, I believe. And after that, I did a couple of case reports in the Dutch article, so also to explain how to use the PNF approach on specific patient and clinical situations. And then I thought by myself, why not in English? Now, and in that time that I graduated, we only had a bachelor degree. There was no master degree. There was no PhD degree. That didn't exist. That evolved in the late 90s, early 2000s. That internationally, they developed a master program on several universities. So I had to do a master in the Netherlands to stay up to date with the requirements of the profession. So I did my master in manual therapy, but still I said, why not use that manual therapy in neurology? Because an hemiplegic patient, to my opinion, still has a skeleton, still has muscles, and still has joints. And
Yes.
if you treat, of course, spasticity, or other structures, they still are within their structural limitations. So why not change with manual therapy or try to address the joint components, the tissue components, and then integrate functional task training. So I did a study to get my master degree with a group of patients where half of them got a manual therapy approach and half of them only got functional task training, which was advocated in the guidelines, that last one.
Yeah.
And the manual group did better because that was integrated manual therapy and functional task. But the pre-requirements for that functional task, a good mobility in the wrist, for instance, for reaching and grabbing, that was, of course, also addressed in this manual approach of glides and tractions of the joint.
Yeah.
And that paper of that study that I did was graded with a very nice final result for me in my master degree. But I said then also, when it is a master degree, the idea of a master is teach your colleagues. With other words, make publications. So I turned my final paper into an article, and that has been published in the Journal of Hand Therapy, the International Journal of Hand Therapy. That was quite a struggle because, I wasn't used to write in English at that moment. I really had to learn to write in an academic way. So I got it back with quite some feedback from the reviewers, almost to a disappointing point. But with the aid of my supervisor at the university at that time, he said, okay, we'll do it together. I'll help you through that process so you learn. And then it was accepted and it has been published. And from there on, I said, okay, wait a minute. When I now know how it goes, I can help others. So we started as the research committee also to sample articles. And we wrote together with the research committee of that was back in 2015. It was published in 16. So we did the research in 14, 15. How many papers we found at that time. And we put them together in a descriptive narrative. So it's a narrative review. And it has been published in a quite big journal back in 2016. And until now, that article of us, that was from Agnieszka Stepin, from who were all in there? Me was in there, Agnieszka was in there, Karsten Schäfer was, of course, in there. Marianne Heitman was a co-author. 1, 2, 3, 4. I miss one. I have to look it up. Then, but that paper has been cited, I believe now, almost like 70 or 80 times so as a reference in other papers and studies. So it is that was really a nice issue to see that our work has been valued in other researchers, that other researchers use our research. So I'm happy about that.
Yes.
And what I still see in a lot of research is that they misunderstand quite often the PNF concept. That they say PNF is this or that, and I think, but that's not PNF. That's maybe this little bit of so much PNF, and they make a statement about this when they only studied that a little bit over here, and that's what I criticized. So I started to publish other papers like, okay, what is the clinical application? Explain what PNF is, what principles are, what procedures are, what techniques are, and that they are not the same. And quite often they mix them as, a principle is a technique, or a technique is a principle in a lot of papers. What is not correct? Yes. So then I addressed that a couple of times with a clinical example. So I published 2 or 3 case studies together with Marianne Heitman once, and once with a student of mine. His bachelor work in an orthopedic way was a case study, and with from Brazil.
Leandro.
together with him, we published a case study on a hemiplegic patient on wrist and hand function. With my student, I published a paper on shoulder impingement, and with Marianne Heitman, I published a paper with a total hip replacement where there was a pelvic malformation. The person we discovered after he came with his complaints, and we had with the surgeon an X-ray. He didn't even know. We discovered he had no pubic bone.
No, wow.
So that means he also has, of course, an issue with his pelvic floor. And he had a hip dysplasia. And then I studied, okay, we see quite often skeletal malformations together with intestine malformations.
Yeah.
And the young man, he was 40 something, he also had a stoma. So he had that from childhood on. He knew that, but he didn't know that he had no pubic bone. But basically it belongs together. So yes. That is such a rare case but that's interesting to see how to treat that. That's not a simple total hip replacement. It's a total hip replacement with difficult circumstances. He needs re-education and motor learning of his gait. Now, that was published too. Great. With these principles and procedures of PNF.
Yeah.
And I think that makes me happy that other people use that, because also all these publications have been cited several times. Not so much as the big one, but this one, yeah.
Yeah, this brings me to two other points, because you are also teaching different medical professions, right? And can you tell us a little bit which profession you are teaching?
We teach. I teach mainly the physiotherapists, because I'm connected to the Department of Physiotherapy of the School of Health. That's the name, and the School of Health or Academy of Health is a department of the university in Enschede, Saxion.
Yes.
And that School of Health or the Academy of Health has a nursing department, so where we educate nurses on a certain level. We have podiatry, and we have physiotherapy. And podiatry, of course, has to do with feet and gait. And in the nowadays, feet quite often with diabetic problems, polyneuropathy problems. But from the feet, quite often statics. So that means low back pain, neck problems, orthopedic musculoskeletal issues. And those three professions are the three parts of our Academy of Health at the university. I'm to 80-90% connected to the to teaching in the PT department. But of course, when gait, for instance, and gait analysis and gait treatments is the topic in podiatry, then I used to be a part of that. And in nursing, we cooperate. We say, it's not just nursing and physiotherapy; it should be team.
Yes.
So there are classes where nursing students and PT students have to learn to cooperate, and that's quite, of course, often with bed transfers, chair transfers, and then, of course, we come. What should the nurse simply lift a patient out of bed, or should it be a kind of therapeutic lifting? Great. So it becomes a motor learning moment, and they should cooperate with PTs who use the transfer, getting out of bed, as a strategy for improvement of movement qualities.
Yeah, but I think this is very important, like you said, to integrate other methods to PNF. It's also kind of teamwork. Use the best from your own knowledge and also work together as a team with other medical professions. Very nice, very good. And the next question comes in my mind. You also taught a lecture, because you were talking about bringing structure in this research, and I think your lecture on our online congress a few years ago was also bringing structure in our PNF concept. Was not a title, but I just would like to talk about your lecture from the online congress.
Yeah, well, I did I did 2 times. I did on the
Oh,
very first
really?
one. I did on the
Yes,
very first one, and that was a little bit a very large and long presentation because
yes.
I made 5 smaller ones, but the organization coupled those 5 together in one long one, which was not the idea. It was more like, okay, choose what fits best, or make it. But okay, yeah, the idea is that basically, like my latest one of my no not latest publication of 2022, that was the essential elements of the PNF concept. And yeah, what are now the essential elements of PNF? When we talk about PNF, or when we explain PNF, we say we have 3 main pillars. We have a philosophy, a way of thinking, and we have a set of principles and procedures that always have to come back because that's our concept. And we have a set of techniques. And the techniques, you could say that is a methodical approach, because that's always a technique is a technique. But the technique addresses a certain problem. The technique is either meant to mobilize, or to strengthen, or to stabilize. And that's why we have stabilizing reversals, or repeated resistances, so like repeated movements. Um, but during a technique, you provide tactile stimuli. And when you give a stimulus, tactile doesn't say so much, because, yeah, when I just stroke you, it's a tactile stimulus. When I slap you, it's a tactile stimulus. So the word tactile stimulus doesn't say so much until you say, yeah, with my tactile stimulus, I give an approximation, or I give a resistance. And both are tactile stimuli, but of course, together with something else. And that are the principles within the technique.
Yeah.
And then we come like, yeah, we have a way of thinking. Why do we think that is good? Because we say, yeah, we need to be functional. A functional approach is one of our key features to stimulate the whole person. Well, when I give a resistance to my wrist, then per definition, I have an stabilizing effect on my elbow. Otherwise, I can't move my wrist independently. So there
Yes.
you see already, yeah, but to stabilize my elbow, I have to stabilize my shoulder. So you see already slowly that a resistance and a tactile stimulus addresses more than just the local hand. It addresses the
Right.
total limb, and therefore the total body. Because, yeah, when my limb wouldn't be stable, then my trunk has to be stable as well. Now, yeah,
Yeah.
with that word,
Great.
you see, it's a total approach, philosophy. It should be functional, philosophy. You
Yes.
use principles of resistance, tactile stimuli, wording, approximation within a pattern of muscle activations and movements,
Yeah. So we
principles and
can,
procedures with a
yes.
technique. Yeah, and that structure is maybe what you meant, that I
Yeah, yeah,
addressed.
yeah, yeah. Yeah, I just would like to promote also that the listener can still apply to our foreign online congresses
Yeah,
and point out that
yeah,
in this moment I have had only one lecture in my mind, but you are right. So if they like to see, they can have the lectures
yeah,
and not only the coming online congress. Yes. So, and slowly coming to an end because you are contact with students, with young people. What do you think, or what comes spontaneously in your mind when you think what is important to give the young colleagues from your side with them for being PT or going in the
I,
way we oldies, we are still burning for our profession, right? We are still
yeah,
burning for PNF. So, but I know from some young PTs they struggle sometimes. So the
yeah.
idea is, what would you say to them?
I
Yes.
recognize that has, I think, to do, it's my personal view, with the focus in the education is so much on scientific backgrounds that they need to say have a kind of proof or evidence, as we call it then, for their approach. But evidence is something that is proven common sense. So And we say, is there evidence? Well, I always say a simple example. You have two people who want to run a marathon, and one gets training every week 3 times, and the other one only once in a month he goes for a walk. And a year later, who will do the marathon the best? Probably the guy who will train every week 3 times. So when you transfer that stupid example to research, quite often you see, okay, we have a treatment in a certain group, and in the other group, we have a control group without the treatment or with just basic information and self-management. Who will do better? And then the outcome is, yeah, of course, the intervention group did better. And I think, yeah, that's common sense because that's someone who gets personal stimulus.
Yes.
But you can only do that evidence when you have skills in your hands. So when you only know how to look into literature as a young starting colleague and say, yeah, I see there is proof, but you don't have the skills in your hands to stimulate your patient. And if that is a PNF skill or another treatment skill, that doesn't matter so much. As long as you have skills in your hands, we should be physical. That's why we are called physical therapists.
Yeah.
And the tendency is going into coaching. And coaching is talking and stimulating by
Yes.
wording. And when you only talk to the patient, yeah, you really can do that. Trust yourself. But the patient has the experience. Yeah, but I always fall, so I don't trust myself. Then make him experience with your hands on that he is not falling. And then you will see, oh yeah, functional gait training or other task training is successful as long as you stimulate and make the patient experience he or she is able, but that requires hands-on. And that hands-on is, to my opinion, a part that is challenging for the younger colleagues more and
Yes.
more.
Yeah.
And that's what they learn in our courses. And that's why I still believe that a lot of participants are always happy after a course because now they get the tools in their hands where they learned in the lectures at school or at universities. They learned there is, but not so much how to do it. And that was in our years, say 30, 40 years ago, different.
Yeah.
I don't say better. We have maybe less background
Yeah.
understanding at that time, and we did a lot of skills that were maybe not always fitting
Yes.
to the client, but it is also, you need a mixture of both.
Thanks a lot for this statement to keep the hands on. This is what I'm thinking also quite often with all this study and research. Even we all did it. So thank you very much. Thank you very much. And
Welcome.
I hope we keep on going for a longer time and
Yep.
looking forward to see you next time. Thank you, Fred.
You're welcome.